So at the current state of affairs, where we have second-line immunotherapies that we routinely give, for pembrolizumab, there's guideline to look at PD-L1 expression, but for nivo and atezolizumab, those recommendations don't exist. So Naiyer, do you test, and if you have a result available, does it influence which drug you choose? How do you use the information?
I think it's hard to really choose a drug for second-line therapy between the three. Clearly for Pembro, the label is more than 1% PD-L1 expression. I think all three are totally reasonable options. I think that rebiopsying, it's not going to change your management, so the PD-L1 assay doesn't really help you. Some of the data that was updated at ESMO 2017 was around the OAK study and the biomarker that was used. I think that there was some question about how well SP142 performed and how to interpret the OAK data. So they actually, for the patients where they had tumor blocks available, which I think was a little over half, they rescored the patients with the 22C3 assay. And interestingly, for patients who have no PD-L1 expression, by either assay, I think by SP142 it was hazard ratio was 0.55, and by 22C3 the hazard ratio was 0.61. So this is interesting data because the hazard ratios for the PD-L1 0 patients with a Pembro and Nivo have been more closer to the middle. So I think that data was pretty interesting.
So phenomenal memory, first of all,
for
remembering.
I was looking at my paper. I wrote it down.
Very good. But I think that you would then advocate that if in doubt, atezo would be the drug you might choose.
I didn't think that before, but maybe I'm getting there. Yeah.
Yeah, Ram?
I think increasingly now with the first-line use of checkpoint inhibitor for the high expressors, you're going to be left with a low expressing population in the second line. And to me, as Naiyer said, all three drugs have comparable efficacy. The difference, Nivo is every 2 weeks, the other two drugs are every 3 weeks. So from that standpoint, for patient convenience, the every 3-week drug may be better. I don't think there's a big difference, clinically speaking, between these drugs at this point.
Yeah, so they're largely interchangeable.
Interchangeable.
And Roy, anything you would want to add to that?
No, I agree, although I was intrigued by the atezolizumab data at ESMO as well. The fact that when they compared the two assays, they were seeing activity in the negatives. So I think the every 3-week schedule there, if you have a negative patient, might give that a little bit of an edge in the future. Certainly pembrolizumab for the 1% or more based on Keynote-10, very reasonable as well. I think these are all going to end up being backbones for combination in the future.